52-year-old man has 30 minutes of sudden onset double vision and headache. He has hypertension, type 2 diabetes mellitus, and atrial fibrillation managed by lisinopril, metformin, and apixaban. On examination, there is a failure of left eye adduction, ptosis, and a dilated non-reactive pupil. Which is the next most appropriate management? A. Endovascular coiling. B. Intravenous alteplase. C. Intravenous methylprednisolone. D. Lumbar puncture. Or E. An urgent non-contrast CT head. The correct answer for question 8 is E. An urgent non-contrast CT head. Based on the presenting features within the vignette, the presence of a dilated non-reactive pupil is in keeping with a diagnosis of a surgical third nerve palsy. In figure 21, we can see the three most commonly encountered ocular palsies. The first is a third cranial nerve palsy, which involves innervation of the oculomotor nerve and subsequently results in a down and out appearance with ptosis. The abducens nerve, cranial nerve number 6, innervates the lateral rectus muscle. Therefore, a palsy results in a loss of abduction. The trochlear nerve, which is cranial nerve number 4, results in an extorted appearance due to the loss of the superior oblique function. The oculomotor nerve consists of two distinct pathways. The outer parasympathetic fibres, which supply the ciliary muscle, responsible for accommodation, and the sphincter pupillae, involved in pupillary constriction, and the inner somatic fibres, which innervate the levator, palpebrae superioris, and the four extraocular muscles, the superior, middle, and inferior recti, as well as the inferior oblique. The lateral rectus is innervated by the abducens nerve, cranial nerve number 6, and the superior oblique is supplied by the trochlear nerve, cranial nerve number 4. Common causes of cranial third nerve palsy include vascular ischemia, particularly in individuals with diabetes mellitus and hypertension, as well as trauma, intracranial neoplasms, hemorrhage, and congenital defects. A surgical third nerve palsy occurs when external compressive lesions, such as an aneurysm, uncal herniation, or tumour affects the superficial pupillomotor fibres, which control pupillary constriction. Aneurysms of the posterior communicating artery, as shown in figure 22, presents with pain and a fixed dilated pupil. In contrast, an ischemic third nerve palsy, commonly attributed to diabetes mellitus or hypertensive microangiopathy, affects the vasa vasorum supplying the nerve's inner fibres, while sparing the superficial pupillomotor fibres, resulting in a pupil-sparing third nerve palsy. A cranial third nerve palsy classically presents with ptosis, due to levator palpebrae superioris paralysis and ocular deviation in the down and out position, as the intact lateral rectus and superior oblique muscles pull the eye laterally and downward respectively. Divergent strabismus is often observed. Pupillary findings vary depending on the underlying cause. A compressive third nerve palsy results in fixed dilated pupil with loss of accommodation, whereas an ischemic palsy spares the pupil. Diplopia is a key symptom in all cases. A midbrain stroke affecting the oculomotor nerve fascicles and adjacent corticospinal tract results in Weber syndrome, characterized by ipsilateral third nerve palsy and contralateral hemiplegia. The diagnosis of an oculomotor nerve palsy, especially in the context of a diluted pupil, requires urgent investigation. The first step is a non-contrast CT head to exclude subarachnoid hemorrhage, which can present with similar symptoms. If a subarachnoid hemorrhage is excluded, further testing is warranted in suspected intracranial aneurysm cases. The next diagnostic step involves an angiogram to confirm a posterior communicating artery aneurysm or other vascular abnormalities. If a third nerve palsy is isolated, a contrast-enhanced MRI or CTA is recommended to assess the risk of an underlying intracranial aneurysm, which is a key concern in these patients. Management depends on the underlying cause of the third nerve palsy. Endovascular coiling, as shown in figure 23, E and F, is the preferred treatment for aneurysms, particularly in cases involving the posterior communicating artery, as it is less invasive and has a quicker recovery time compared to surgical intervention.